Good afternoon to all of you, and welcome to Capdoula webinar. So this is an important step for us as it's our first webinar in English. So some of the participants are regular attendees. Some of you are totally new, so welcome, and thank you for joining us. As you can guess from our name, our webinars are always about pain management. And for this first webinar in English, we're going to talk about pain and surgery. So I'm pleased to welcome the three lecturers for today, Professor Viguier, Dr. Philippe Buttin, and Dr. Thibaut Cachon, who are going to share with you some of the latest innovation in surgery, innovations which, amongst other advantages, can significantly help in reducing post-surgery pain. So the lecture will last approximately 40-45 minutes to save time for the question at the end. So if you have questions raising up during the lecture, please use the chat and we will answer as many as we can at the end of the session. So I'm now handing over to Victor Robalo from Novatek Surgery, our partner, who's going to introduce the session. Enjoy the meeting.
Thank you very much, Laetitia. So I'm Victor, the CEO and the co-founder of Novatek Surgery, and I will just briefly, say thank you to Capdoula for the organization of this webinar and to all the surgeons for their participation and all the attendees. I will just briefly present our company, which has been created in few years ago in Monaco and which is benefiting of several decades of experience in human implant manufacturing. We decided a few years ago to dedicate this know to the veterinarian surgeon and to help them to maximize the benefit of this treatment or to minimize the animal pain, trauma, and recovery time. And this is why today, three surgeons will present you the physiological technique we developed for CCL repair, for tendon repair, or as well how we can manage the pain in post-operative surgery with cryotherapy breaths. I will now let Viguier, which is from the University of Vetagro in Lyon, France, who is working with Dr. Thibaut Cachon in the same university, and then Dr. Philippe Buttin will talk about the tendon. Philippe Buttin was a referral activity in the French Alps in France as well. Professor Viguier, I now leave you the speech.
Cruciate ligament rupture. Could you change slide, please? Oh, sorry. You hear me? Do you hear me? Change. Oh, okay. As you know, the rupture of the cruciate ligament is one of the most common. Don't change. Don't change. First, yes, the most common cause of traumatic lesion of the pelvic limb in adult dogs, and it represents a lot of money in USA. We can evaluate the price of this procedure for the clients about $2 or maybe more trillions of dollars. It was 1.73 in 2003. And the rupture of the cruciate leads to osteoarthritis. For the dog, it's painful, and the only way to treat correctly this affection is to do a surgical treatment. You can find many techniques, and it's more than 100 techniques to repair were described. And actually, the gold standard is the TPLO. As you know, the limit of the TPLO is a surgical trauma because of the section of the bone of the osteotomy, and you know it's painful. The procedure is not basic, and it needs some experience and a specific equipment. The duration of the post-operative sometimes could be long, and we know that we can find some major complication. Slide, please. So we have other alternative to the TPLO, and as you know, we have different ways to treat them. You can use an extra-articular technique, or recently we've developed a new way of intra-articular technique with new artificial ligaments. The flow techniques with an extra-articular technique is only used on small dogs, and if you do modified technique with 3-in-1 technique, by example, it's not enough strong sometimes, and the post-operative is sometimes not enough good. And you can improve the technique with the tri-rop technique and the tri-rop ligament, because you increase the isometry and it's better. Oh, sorry, I have no more slides. I have no more slides, please. Oh. Okay. Could you change the slide? Okay. I don't see the slide. Oh, do you hear me? Sorry.
We have a small issue. I will send the slide.
I have no slides. Sorry. I have no, yes, sorry. So, before, well, yes. The alternative to the TPLO is the use of intra-articular ligament. You know, we have done before with the fasciolata for the over-the-top technique, but we know that the ligament is weak. And with the new ligament, it's possible to have a very strong repair and less inflammation than before with this ligament. The benefits of this technique are simple, fast, and less aggressive, no osteotomy, and a low morbidity. So, in this way, you can have, for the dog, less pain. Slide. The CCL repair with the intra-articular ligament need for this technique some interference screws and ligament. In this technique, we will use ultra density polyethylene ligament, and this ligament is passed through 2 tunnels who are drilled at the insertion of the cranial cruciate ligament. And the ligament is fixed with the interference screw. You can see on the X-ray a ligament fixed with 2 interference screws. Yep, slide. Victor, slide.
I think it's good.
We have developed some study with this ligament, and we have some results in biomechanics and in clinics. In biomechanics, we have proved that we can fix with 2, 3, or 4 screws, and the fixation with 4 screws better than 2 screws and 3 screws and 2 screws. The fixation of the quality of the fixation of the ligament is better in the femur, less in the tibia. With 4 screws for the fixation, we have quite the same maximal force that the native ligament. We can replace 4.5 millimeter screws when you lose it with a 4.5 millimeter in the same hole. We have also proven that in a dynamic study, after 100,000 cycles, we have no more than 2.5 millimeter of elongation of the ligament. It's compatible with the good use of the ligament. We have developed some new screws, and the strength is best than the old one. And we have also shown that the implantation of screws in the articulation from the insertion to outside is better than outside when you want to fix the ligament. In clinical research, we have developed a special guide to drill the tunnel to have a real improvement of the technique. The new screws are very easy and quicker to use. And it's possible to use arthroscopy to be less invasive and to have a best implantation of the screw close to the ligament. So I lose the picture. I need the... In conclusion, I want to tell you that this technique is simple, less aggressive than in TPLO. It's possible to do with a traditional approach, with a mini arthrotomy, or with arthroscopy. With this technique, we can say that it's less pain for the dog, and we have an easier recovery. You can look at the first picture, the technique with arthroscopy, and the dog who has been repaired. So the problem with the video, yes. Yeah, thank you for your attention.
So, Professor Viguier, we can check if you want if there is any question in the chat.
So there is no question?
For the moment, I don't see any questions, so we can move to Dr. Thibaut Cachon, who will deal about the cryotherapy brace in post-operative pain management.
Okay, so good morning, everyone. I would like to thank you, all of you, to be there to attend this meeting. I will try to be fast and to introduce you the cold compression therapy that we develop as a brace with Novatek. And as you all know, cryotherapy is next slide. As you all know, cryotherapy is the application of cold in rehabilitation and physical therapy. You can associate cold and tissue compression in order to improve the efficacy of cryotherapy. Next slide, please. Cryotherapy is mainly used to decrease pain, to decrease inflammation, but also to reduce edema. And it's most of the time, there is, so you can change slides. Sorry, Victor. Thus, cryotherapy is used to reduce inflammation by reducing the metabolic activity by inhibition of inflammatory enzymatic reaction, and also to reduce release of histamine. This also protects the tissue from damage. This reduction of inflammation is also increased and is also added because of vasoconstriction, which is induced by cryotherapy. This vasoconstriction induces reduction of inflammation, but also a reduction of the edema, which will be very interesting to decrease pain, because edema, tissue edema, is the main component of pain in traumatic injury. At least, and not the at least, cryotherapy is also used to reduce the nerve conduction velocity, which will increase the analgesia in postoperative care or in traumatic injury. If you add compression to cryotherapy, you will increase the vasoconstriction, thus increase the radius of edema, but also increase all the effect of cryotherapy. Thus, compression and work as a synergy with cryotherapy. In human beings, next slide, please. As you can see on this picture, that the efficacy of cryotherapy is increased by cold compression. You can see on the right of the picture that cold compression therapy induces a larger diminution of temperature in the knee of a dog rather than a standard cryotherapy. And it is well known in human being that you need to get at least a decrease of the temperature more or less to 16 to 80 degrees after the cryotherapy to get some efficacy of the cryotherapy. Thus, cold compression therapy is very interesting to improve the efficacy of standard cryotherapy. As you can see on the next slide, in human being, there is very very specific techniques to do cryotherapy that could be used as some brace, specific brace for each joint, but also there is some mechanic cryotherapy units which can in postoperative care. Thus, unfortunately, those specific units are very expensive and most of the time are not very easily to use in dogs. And to the next slide, please, Victor. And thus, we try with Novatek to develop a specific brace in order to do some cold compression therapy, which will be a brace specific for dogs and specific for stifle in dogs. There will be three sizes, from one size for the dogs between 15 to 95 kilograms, the other and two other sides, and then you can treat dog between 15 to 50 kilograms. It's quite easy to apply, and there is the left and the right side. The brace is used mainly in two situations. As you can see in the next picture, the brace is mostly used to treat acute musculoskeletal disorder, for example, sprain. But in my practice, I mainly use the brace to treat postoperative pain and edema after stifle surgery. As you can see in the next slide, you need to use for the brace during 10 to 20 minutes, 2 to 3 times a day, and the compression need to be done by 5 to 10 pressure into the brace. The brace is mainly used during the acute phase of inflammation. Thus, for the first 4 to 5 days, it is mandatory to use it as soon as possible after the injury. Thus, as soon as possible after surgery, if the brace is used for a postoperative care. There is very few contraindication to the brace. I think that most of the time it's more precaution of use. You need to protect the skin with a towel before to use the brace. You also need to avoid the use of the brace when there is an open wound or where there is some skin with ischemic area. How I use the brace in my practice, I think that currently I use the brace in every stifle surgery, such as TPL or TTA or into stabilization. But also even after simple arthroscopy or treatment of patellarization. I use the brace, as you can see on the slide, as soon as possible, just after surgery. During the waking up of the dog, just after the X-ray, the dog gets his brace during 20 minutes, just after during the wake phase of the dog, which will increase the efficacy of the cryotherapy. Is to use it as soon after the injury, and then I use the brace, as I already said, at least 2 to 3 times a day during 10 to 20 minutes each time. And I use it at least for the first. You can use it a little bit more, which is also possible. In human beings, sometimes they use the cryotherapy during 10 to 15 days after surgery. It's quite easy to use. I think that there is new way, perhaps new perspective by using those brace, which could be using this brace in a preoperative therapy. As there is a study who show that using the brace before the surgery could be more efficacious than using it just after the surgery. We need to keep on going on this, perhaps to use it as a preemptive analgesia before the surgery. And I think also that the brace could be used in other kind of joint. I use it also, for example, in tarsus or in elbow. For example, in elbow, in postoperative care after elbow arthroscopy, the brace is quite easy to use also. As a conclusion, I would like to thank, first of all, Novatek to develop this cold compression brace, because from my point of view, it's clearly a part of the multimodal analgesia of the dog in stifle surgery. The brace is very easy to apply and is, compared to other brace available in human being, is very cost effective in more and more practice. I would like to thank you for your attention. If there is one or two questions, I can answer quite easily.
Thank you, Dr. Cachon. So we can check in the chat if there is any question. And for the moment, I don't see any. So we can move on to Dr. Philippe Buttin for the tendon reconstruction, and we will check for all of your free presentation if there is any question at the end of the conferences. Thank you very much, and Dr. Philippe Buttin, the floor is yours.
Thanks. Okay, so do you hear me? Yes.
We hear you very well.
Okay, so we are going to talk about articular ligamentoplasty here and tendon reconstruction with synthetic implants. It's been a long time now that we've been working on these implants. You can see here the Novatek implant product as a tendon or ligament. Here is the tendon synthetic one. You have two possibilities. You have the 4,000 and the 8,000 Newton, which is a very, very strong ligament, and you have different size of screws. You can see on next picture that we are talking here also more about the Achilles tendon pathology, which is what we've been working a lot these few years ago, these past few years. So you can see, you know that the pathology tendon can be rupture, as you can see on the left photo, which is representing a dog with a complete plantigrade. He is completely plantigrade, but the one on the left hand side on this picture here, you can see a claw position, which means that this dog has a partial plantigrade. So this pathology, in fact, has many different ways and also many different ways to treat. On next picture, you can see all these indications and all the different pathology that you can find on the Achilles tendon. You can have a complete rupture, like a gastrocnemian, the photo you've seen, with the flexor digit superficial. So that means that when you have a complete rupture of this both ligament, you have a plantigrade dog. When you have a partial rupture, it means usually that you have an intact flexor and the gastrocnemian that has ruptured. That means for the dog to have a claw position, as you've seen on the previous slide. You can have also enthesiopathy with mainly the gastrocnemius. This leads to pain and lameness for the dog, and we have low diagnostic probably of this pathology. So I encourage a lot people to do more ultrasound or MRI, of course, but ultrasound is already very good to assess these dogs. We have also tendinitis and elongation of the tendon. We have sometimes on the flexor lesions on the heel cap, and again, you can have partially plantigrade dog, but also you can have pain and lameness. These again are sometimes low diagnostic, and we need to do ultrasound ideally to find them. The worst ones are musculotendinous rupture with a variable plantigrady again. Sometimes very difficult to see and to diagnose. So if you want to have a very good diagnostic, again, you should work with good ultrasonographer. Next slide, please. Next slide. Yes. So we decided to do a new technique, decline from the Morton ones from the VCOT in 2015. But this technique is differing from the Morton ones because we do a transcortical output tunnel. So it's not a blind tunnel, and we do after this a perpendicular tunnel. It means that we can have probably, and that's what we showed in some papers that are going to be published very soon. We have a higher resistance to loads, and we have also very nice possibility to place the tension of the prosthesis very easily. You can judge that more easily than before, just because you don't have a blind tunnel. So you can see on the pictures that you go through the calcaneum and then you go transversely with an interference screw. On the next slide, you can see also that our technique is differing a little bit because we incise tendon lengthwise at 50% of the diameter. Then we are doing either a continuous pattern or simply stitches with polypropylene O0. So you can see on the slide all the stitches here. Usually we put 8 sutures if we do single stitches, or you can do a Chinese finger knot with a continuous pattern with fiber wire, which is working very well also. On the next slide, so what is very important here, of course, is a tension test. So we are trying to assess the dog. The better is to test the dog on both limbs before surgery so that you have an idea of this particular breed and what the tension is. But roughly, it's something that we are quite used to, because when you do the compression test, when you are doing a crush ligament disease, you already know how much tension you have in this test. So ideally you put the knee in extension and then you flex the tarsus, which leads to a resistance on the non-pathologic one, on the non-pathologic tarsus. But on the other one, of course, you will have a problem. So the fact in this surgery is you can adjust the tension exactly at the time that you want. When you achieve the tension, then you can put an interference screw in the perpendicular tunnel, and then the implant is locked definitively. On the next slide, please. So here you can see the biomechanical study we've performed in 2019. We had 8 sample cadavers, and we did this to know how much Newton we had before the rupture of the implant. On the next slide, so you can see that the interference screw interface between so the bone and the implant was very, very high, going up to 1000, which is very nice and a very good surprise. We were above all literature done until now. On next slide, we can see the results of the tendon suture. Again, we were very high, around 700 Newton, which is high and more than walking dog or trot dog. So, of course, we were very happy with these results. So, again, that was very high and above literature. Do you have the next slide, please? So this is a comparative bibliography, and we were around 50% to 150% more between bone fixation or muscle fixation, or it means tendon fixation. So this is the best that we had until now. Next slide, please. Okay, we performed also a clinical study since 2016 on 10 dogs, and we had put bandage with brace or half valves for 6 weeks on most of the dogs. We had really an excellent functionality at 8 weeks. We had no dehiscence, no calcaneus fracture, and 1 infection. We were lucky because the removal of the prosthesis at 4 months with antibiotics before, of course, conserved the functionality, so we didn't have a catastrophic reoperation to do. On next slide. So the average of the surgery was 80. Just before, please. Yes, 80 minutes. We had so excellent functionality. Yes, it's almost the same slide here, no? So you can squeeze for the next one. Yes. So the most important, of course, is the benefit that we can have here on this technique compared to other ones. We most of the time don't have a very rigid immobilization because we are not using external fixation, and sometimes we are not using valves, resin. So that's it's very good point, because we are against ankylosis. You know, we are avoiding ankylosis as much as we can with this technique. Because of the postoperative care. The very good point also of this technique is that patient and indications, because we have a large variability. We can do very small dogs and very great Dan or big dogs, you know. Also, the very big problem that we have in other techniques sometimes is the chronicity, because of muscle retraction and the large gap that you can find sometimes. Also, you can have sometimes calcaneus fracture at the anthesis, but with so much bone stock that you can't realize, you can't perform any haubanage. So it's nice because this technique is doing the job very nicely. Also, we can do anthesiopathic chronic lesions, and that has very, very nice results, because we had no lameness after this surgery, and the dog had big problems before. So we avoid, as I told you, as much as we can external and internal fixation, complication, as infection or descents. The problem, of course, you cannot avoid the fact that it's your asepsy must be perfect on this surgery. And if you have any septic wounds or open wounds, you shouldn't do this surgery with an implant that is going to infect. Next slide, please. Okay, so it's time for questions.
Thank you very much, Dr. Buttin. So let's check if there is any question.
I think that there is one or two questions about the brace. I'll check it on the chat. The first one was if there is any concern about loss of temperature by using the brace just after surgery. In our practice, we didn't get any problem with the loss of temperature during the waking up phase of the dog with cryotherapy. That says mainly a local hypothermia, and I think that there is no contraindication to use it in during this phase of the waking up. Of course, you need to keep the dog with a good temperature just for the surgery, but it's not a concern for me to use a cryotherapy brace during the phase of waking up. I think it's not a big deal. The other question was about cost of the brace, and I think that Manuel and Victor will answer to that question directly, because it could be different from one country to another one. Okay, if there is no other question, it's I think for me.
Definitely, we invite you to any price or technical information on the product itself to contact directly the company or Manuel Garcia that has left his mail address into the chat, and we will either give you a direct answer or send you back to your local distributors. I don't see any other question regarding cryotherapy brace, neither regarding ligament or tendon reconstruction for the moment. All right, there is one question for cryotherapy brace by Sarah Olemans. Should these braces be frozen or cooling?
Yes, in fact, inside of the brace there is a cooling pack. You need to put it in the fridge for 1 to 2 hours, and it will keep more or less a good 4 degrees during 1 or 2 hours after the use of the brace. So it's you need just to keep the pack in the fridge.
Thank you. There is another question for Dr. Philippe Buttin by Simon Kugnig. Is your transverse bone tunnel distal on the limb or proximal to the longitudinal bone tunnel, closer to the tarsus? You just need to reactivate your microphone.
So, yes. So yeah, the transverse bone tunnel is distal to the first tunnel, and it's a little bit closer to the tarsus. We are also. It's very important also when you do these holes, these bone tunnels, that you have the diameter of a complete screw on any part of the calcaneus, not to avoid, of course, fractures. It's very important to avoid these things.
There is a second question for you that is, so you keep hook flexed while inserting the interference screws?
So you keep the hook flexed while you inserting. So no, in fact, you must choose your tension on the implant while this implant is positioned, of course, into the two bone tunnels. And when you are okay with this, you can put a kosher clamp that will maintain the tension. And then, yes, it's a little bit good to keep tension on this, but you don't have to do a very high flexion of the tendon. The only thing that matters is that the implant is tensioned in the bone tunnel so that it's facilitating the insertion of the screw. So
there is two other questions, one regarding the CCL, but Professor Viguier seems to not be able to answer right now. So I'll continue with you, Dr. Buttin. Where was the point of failure in the Achilles repair during cadaver testing?
So most of the time, so we tested both parts. We tested the interference screw on a part, and we tested the sutures on another part. So I can tell that the point of failure regarding the interference screw was in fact that the implant slided inside the hole, and because of the tension. So the tension at one point was so high that the implant was able to slide a little bit inside, and that was the end of the test. Concerning the suture ones, at each time when we did the simple stitches, we always have a breaking, a rupture of the polypropylene, and not at the knot size, and not at the knot location. So all the knots that we had done, everyone never failed. So always the problem was always the suture that at one point broke.
And we have another question that is, can we use bioscaffolds in dogs for good recovery as in human?
So I guess yes. The problem is always to know what is this bioscaffold is giving as a biomechanical resistance. So that's what we can say. But the bioscaffold on this implant is for now very difficult. If you want to apply it on our implant, it's not done yet.
Dr. Vincenzo Santoro, get back to its first question, which was, so you keep hooked flex while inserting the interference screw. He added hook, so you clamp one side, thanks, but do you keep as starting reference the standing angle? So I think he would like to know on which position you have of the leg when you manage the tension and the fixation.
It's exactly that. So you need as a starting reference the standing angle. It's exactly the problem. So usually we are putting the interference screw when we are in a standing angle, but the most important, I would say, more than the fact that you put the interference screw, is to find the good angle that will matter for the dog. So that will be a normal standing angle for the dog.
Thank you very much. At this point, we do not have any other question. We had one question back to Professor Eric Viguier, which was concerning the outcome like after surgery of the CCL and physiological repair and comparable to TPLO. Professor Viguier, I don't know if you can hear us. You have your microphone unused. Professor Viguier, can you hear us? All right, we can hear you now.
I increase the volume. Yes.
Now we can hear you very well.
Where is the question?
The question was asked by Dr. Joe Fox.
Yes.
What are the outcomes like after surgery? And is it comparable to TPLO?
Hi. So concerning the outcome, during the first 4 weeks, the problem is that the dog must be very quiet because of the quality of the fixation. The fixation is only maintained by screws. We are sure that now the new shape of the screws allow us to have a fixation, a good fixation for the trot, for the walk and the trot. But if the dog is quiet, the fixation during the first month is enough. After 1 month, you have the soft tissue and fibrosis who comes in the ligament and create a wound or a wound healing between the bone and the ligament and maintain strongly the ligament. So the post-operative is quite the same as post-operative that we had before with the fasciolata, because we have not enough experience for the moment to be sure that we can have a recovery quite the same at 2 months. The ligament is strong, the fixation is strong, but we have not enough cases to tell that now you can let the dog with a regular activity at 2 months. So for the moment, we must be careful during the 4 first weeks, and after increase progressively the restriction, to decrease the restriction of activity and to increase the walk, increase the trot, and after the dog will be able to run normally.
Thank you very much, Professor Viguier. We have another question for you. How many cases till now, maximum follow-up and rate of infection in your practice, any acute breakdown? This is a question from Dr. Vincenzo Santoro.
For Buttin or for me?
For you, Professor Viguier.
I am looking for Vincenzo. How many cases till now? Yes. For the case, the problem is not was not the infection. The problem was more slipping of the ligament, because we had the old version of the ligament and the fixation, and we use the same way of implantation that total hip prosthesis. So the problem is not the infection, but was more the slipping of the ligament for some dogs, and particularly the large dog. It's the reason why we have modified the technique and modified the screws. It's not a breakdown, it's more slippage.
Okay, thank you. For Dr. Philippe Buttin, there is another question regarding the sutures. When you place your sutures proximally for the Achilles repair, do you place through the split tendon on one side, through the prosthesis, and out the split tendon on the other side?
So we are, yeah, you hear me? Yes. When we place the suture, we are going through the split tendon on one side, then through the prosthesis, and then through the split tendon on the other side. Yes, the question was right. And when we do the Chinese finger knot, it's quite the same.
Thank you. At this point, I do not see any other question.
I see Sarah Oleman that asked for rejection of the synthetic implants. I don't believe that we can tell that there are real rejection. As
more infection.
Yeah, it's more infection, as Professor Viguier say. When you, it's almost like any implant. When you don't have infection, usually, well, I mean bio implants, but we don't have rejection of this. It's very well tolerated, this one, and we are very happy with it.
So for the Achilles tendon, we must be very careful with dog who has bites, who was bitten, because some lesions are infected, and it's impossible to put in the first intention such ligament.
Yeah, you shouldn't. As I told in my slides, don't use this technique if you have any open wound or things like this. Okay.
Well, if there is no other question, I think we can finish now. Thank you very much to the three of you for your conferences and for the time you spent into the question and answer time as well. Thank you to all the participants to this webinar and to Capdula for its partnership for this webinar as well. You can access to this webinar as a replay video as well. Novatek Surgery will try to implement webinar each month because of the period we are living right now. Webinars is a good way of sharing experience. So thank you very much, and we hope to see you again in the next one.
Thank you. Bye.
Thank you. Bye-bye. See you.
Thank you.